So, uh, so I could see many people. I mean, the good morning and good evening, everybody, uh, to this very important session. In this session, we will be talking about the advanced disease management of HIV and AIDS, and in this and co-infection also. And in this session, various important uh, people have joined. I could see Daksha Patel. I could see Mr. Vivek Anand from Humsafar Trust. I could see Julia Vivian, and I could see many other people who have joined. And the first speaker of this session is Dr. Manish Kumar Bagrotia, who is the Technical Director, Project Accelerate uh, from Johns Hopkins University. Earlier, he was working in National AIDS Control Organization, and he has given he was working in the capacity of national consultant in the care support and treatment division, and his contribution is enormous in the field of HIV and AIDS. And I'll be happy to hear you. Rather, you will everybody will enjoy hearing his. I mean, while he will give the take up this session. Uh, he has also contributed in the technical guidelines, which has recently been published, technical guidelines of uh, the care support and treatment. And these uh, he has always been a driving force for National AIDS Control Organization. Thank you, and I welcome Dr. Manish Kumar Bamrotia for the first session.
Hello everyone, I am Dr. Manish Bamrotia. I'll be taking the session on comorbidities and aging, the case of India. I work as Technical Director for Project Accelerate. Project Accelerate is being implemented by Johns Hopkins University and is funded by USAID PEPFAR. Under Project Accelerate, we provide technical assistance to National AIDS Control Organization, India. So as we know, with the scaling up of antiretroviral therapy, the life expectancy of people living with HIV has been significantly extended. ART has transformed HIV from a life-threatening disease to a chronic manageable condition. Even the latest UNAIDS statistics suggest that globally, PLHIV with age more than 50 years have reached 8.1 million. And even in the Pacific region, there are 1.4 million PLHIV living at an age 50 years or older. The program data from the ART centers that we work in shows that approximately 17 to 24% of PLHIV on ART are in the age group of 41 to 50, and approximately 8 to 14% PLHIV on ART are in the age group 50 or above, which suggests that there are a substantial proportion of PLHIV who require a specific package, comprehensive care regarding aging. Coming to definitions, aging is defined as progressive physiological changes in an organism that leads to a decline in biological function and decline of the organism's ability to adapt to metabolic stress, which may result in increased risk of weakness, disease, and death. So aging takes place in a cell, in an organ, and overall in an organism with passage of time. And this is the biological aging. Now, chronological age, which we measure in years, is different from biological age. And the key factors that affect biological age is one, obviously, passage of time, but also the behaviors like smoking, drugs, heavy alcohol use, physical inactivity, etc., genes, life stress, and certain chronic diseases. While comorbidities are defined as a disease or condition that coexists with, but often is independent of another disease or condition. So mostly the non-AIDS defining comorbidities we are going to talk about. Now, regarding the PLHIV and the risk of comorbidities, so there has been many studies, but I have quoted one specific study's HIV cohort study, which has suggested that HIV-infected participant had a significant higher mean number of age-associated non-communicable diseases than controls, with significantly more HIV-infected participants having more than one comorbidity. Hypertension, myocardial infarction, peripheral arterial disease, and impaired renal function were significantly more prevalent among HIV-infected participants as compared to the HIV-negative participants. Data presented in the European AIDS Conference 2021 suggests that increased age, longer duration of HIV infection, and history of AIDS were significantly associated with greater number of comorbidities. It also suggested that burden of comorbidities by age among long-term survivors of HIV resembled the burden in control participants, the HIV negative one, with 10 years older. So basically, it suggested that the biological age changing happens almost a decade earlier in PL-HIV as compared to their HIV negative counterparts. So which suggests that HIV accelerates aging. So these are the graphical representation of the findings. We can see that the prevalence is higher in the HIV infected cohort, and in the other graph we can see the comorbidities, the number of multiple comorbidities also is significantly higher in the HIV infected as compared to the HIV uninfected. Now the reason for this, so there is this inflammation hypothesis that suggests that many pathogenic stimuli induce a similar inflammatory response, causing interleukins, TNF, TGF-beta, etc. to rise in the body. However, with the removal of this stimulation, inflammation generally decreases and healing occurs. But however, in the conditions when the stimulus persists, pathogenic response occurs, which may lead to fibrosis, tissue destruction, altered function, and progressive disease. So all these factors like aging, genetics, obesity, exercise, diet, smoking, chronic HIV infection, ART toxicity, and other co-infections ultimately causes decreased physical functions, inflammation, fibrosis, dyslipidemia, insulin, and which ultimately affects the end organs and thereby causing multiple non-AIDS defining comorbidities. This also suggests the same thing, this figure. So the factors which HIV contributes are mostly the inflammatory, immune activation, CD4 cell depletion, immune senescence, which is caused by HIV, which when coexist with the host features like family history or genetics, habits like smoking, alcohol, obesity, and natural aging process, and coupled with the effects done by antiretroviral, at least certain agents, ultimately combined and makes a person more at risk for non-AIDS defining comorbidities. The commonly observed comorbidities among PL-HIV includes the most common regarding cardiovascular disease, respiratory disease like COPD and asthma, metabolic diseases like diabetes, chronic renal diseases, osteoporosis, visual impairments, anemia, and mental disorders like anxiety, depression, bipolar disorders, and certain types of cancers. So there is an urgent need of non-communicable disease in India. The burden of non-communicable diseases in India is growing, specifically the diabetes, hypertension, and cardiovascular diseases. We can see the changes over the decades when initially in the late 90s, the communicable maternal and neonatal and nutritional disorders were the major areas which affected the dailies. However, the NCDs were limited to 30.5% only. However, 2 decades later, almost the picture has changed and the NCDs have taken the majority. So as of now, NCDs are responsible for majority of mortality in India, account for 63% of deaths, and responsible for 60% of premature mortality. So prevalence of various NCDs among Indian population varies significantly, like cardiovascular disease, around 24%. I have quoted the various studies that are available, hypertension 29.7%, and so on, like diabetes. Again, diabetes, various studies have shown varied prevalence, but there is a significant number of Indians who are having these non-communicable diseases. And that makes a very specific case for India, where NCDs and HIV form a syndemic. So Indian population is prone for non-communicable diseases, and then the Indian PLHIV or the PLHA per se, due to the HIV infection, are having a higher risk. So there are certain studies which have clearly shown that prevalence in Indian PLHIV population is higher than the PLHIV populations in other low and middle income countries. So what we know that there is a significant contribution of traditional risk factors remains for aging and non-communicable diseases, and HIV is likely to increase the risk, especially prolonged exposure to low CD4 count or AIDS. However, we need more answers on the magnitude of problem, and unfortunately, not much of the data is available around this. We need a better way of age progression trends. Many times the age is registered at the time of registrations, and the update does not happen, at least when the person moves from 30s to 40s or maybe 40s to 50s. We also need to know that are risk or effects reversible with the interventions like rapid ART initiation and early diagnosis of HIV? Does management require special considerations? And one of the major important question, that how to deliver. So integrated care is the need of the hour. Integrated care is patient-centered care. Providing additional medical services can enhance retention and engagement in care overall. It may address and eventually reduce the issue of stigma. And there are interactions between drugs which are being, like with ART. So the drugs which are taken for comorbidities and the drugs taken for ART may infect. So there were, hence there is a very important requirement of having an integrated care. So the response in India for the syndemic. So there is two national programs addressing this. National AIDS Control Organization, which was started in 2004 and focuses on extending quality of care to patients living with HIV. And now the targets are around 95%, 95 on the targets are around 95, 95, 95. On the other hand, we have National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. It has started in 2010 and focuses on prevention and control of chronic non-communicable diseases. So both the programs are kind of existing in most of the health infrastructure, and maybe at a district level, at a facility level, there is more scope of integrations. Indian guidelines for PLHIV with aging or comorbidities suggest that all PLHIV, including those with aging risk factors or comorbidities, needs to be initiated on ART, irrespective of CD4 count, clinical stage, age, or population. Rapid ART initiation is now recommended for everyone except for those who are having advanced disease, and dolutegravir-based optimized regimen are recommended for quick and sustained viral load suppression. For comorbidity management among PLHIV, the coordination meetings and planning has been initiated by NACO with the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, National Mental Health Program, National Tobacco Control Program, and National Oral Health Program. Recently launched operational and technical guidelines for ART services has dedicated chapters and instructions for screening, diagnosis, management, and referrals for common comorbidities among PLHIV. The guidelines and the recommendations focuses on 5 major components for prevention and management of non-AIDS defining comorbidities, which are health promotions, screening for early detection, diagnosis, management, and regular follow-up. Under health promotion, all PLHIV, including those with aging or risk factors, need to be counseled for active lifestyle and increased physical activity, weight control, balanced diet, tobacco cessation, avoidance of alcohol, adherence to ART, as well as treatment for comorbidity if diagnosed. Regarding screening, the guidelines recommend that diabetes needs to be screened for all patients at the time of registration or ART initiation, and 1 to 2 months after ART initiation, and then every 6 months, and at a change of regimen. The mechanism is through random blood glucose test. For hypertension, again, the population is all PLHIV at the time of registration into HIV care or ART initiation, followed by every 6 months after ART initiation, or separately as a screening examination if requested by PLHIV or need filled by healthcare provider based on the symptoms. This is to be done through blood pressure measurement. For cardiovascular diseases, again, it's recommended for every PLHIV at the time of registration in HIV care, followed at 3 months and 6 months of ART, and then after that, every 6 months. This is recommended to be done by monitoring BMI and waist circumferences, blood pressure, signs and symptoms of diabetes, examining for signs as pitting edema, heart murmurs, basal crepitations in lungs, and tenderness in abdominal, and lipid profile wherever the tests are available. For mental health, again, all PLHIV are being recommended for screen at the time of registration or ART initiations. And if a PLHIV has a detectable viral load after 6 months or more of ART, and if signs and symptoms are suggestive of mental health. It's being done through Patient Health Questionnaire 2 and Patient Health Questionnaire 9. It also recommends regular screening for certain cancers, which includes oral cancer, all PLHIV with age more than 30 years, and specifically those with having tobacco use at the time of ART initiation. Repeat screening is recommended within 3 years if the initial test is negative, and any other time if related signs and symptoms are reported. It's recommended through oral examination. Similarly, breast cancer is recommended for all women living with HIV about 30 years of age. The WIN remains same, and the method recommended is clinical breast examination. Regarding the cervical cancer, all women and girls living with HIV who have initiated sexual activity at ART initiation, repeat screening within 3 years if the initial test is negative. Women who have been treated should receive follow-up screening at 1 year, and any other time if related signs and symptoms are currently, the recommended method is visual inspection with acetic acid. Regarding diagnosis, management, and service delivery, the guidelines recommends following the existing guidelines for management and diagnosis of these diseases. Initiation of treatment for comorbidities is recommended to be done under a specialist or trained physician within the same institute. Linkage needs to be established, and continuation can be at ART centers as a single window approach wherever possible once the patient is stable on ART as well as comorbidity. So conclusion, with the transformation of HIV into a chronic disease, a significant proportion of PLHIV will need a comprehensive care package. HIV can accelerate aging and adds to the existing risk factors of non-AIDS defining comorbidities or the non-communicable diseases. Knowledge gap on trends and impacts needs to be explored, and innovations are required specifically on the service delivery part. These are the references: National Technical Guidelines of ART and Operational Guidelines for ART Services of National AIDS Control Organization, Government of India, and the relevant papers has been mentioned on the. I thank my seniors and colleagues for helping me this presentation. Thank you.
Okay. I hope Dr. Bawari has joined. I could not find him. Yeah. So I welcome all the speakers once again, all the participants once again, and I welcome Dr. Bharat Bhushan Rewari. He is a medical officer, HIV, hepatitis, STI in the Department of Communicable Disease, WHO Regional, WHO for Office for Southeast Asia Regional Office. It is he is a very important person. He's always contributing for NACO in Indian program as well as outside India. He has published a number of publications, and his contribution to the field of HIV and AIDS is enormous. He has also worked in HIV and TB comorbidity also. So I welcome Dr. Bharat Bhushan for the next session. Thank you, Dr. Bawari.
At the outset, I would like to thank the organizer for giving me this opportunity to present WHO guidelines on prevention and management of advanced HIV disease. We know that the world has missed 2020 target of reducing AIDS-related death to less than 500,000. Despite a significant decline over decades, there were 680,000 AIDS-related deaths in 2020, and this reduction has plateaued despite a major scale-up of antiretroviral therapy. We know that early detection is key to reducing deaths because people who present at late stage have low CD4 count, more severe opportunistic infection, suboptimal response to ART, and consequently poor prognosis. We also know that early ART initiation reduces AIDS-related deaths, and most countries have adopted the treat all recommendations from WHO over the years. So what else can be done beyond early detection and treat all to reduce mortality related to AIDS? This is to show that 33% of people starting ART have got CD4 less than 200 and 20% have CD4 less than 100. In some places, it may be as high as 70%. This is another published study in Clinical Infectious Disease 2018, where data from 46 countries showed that 31% of people start ART with advanced disease across different income groups. Hence, there is a need to differentiate our patients into certain categories and triage them. In 2016, WHO ART guidelines outlined 4 scenarios of people coming to HIV care: individual presenting with CD4 less than 200 or WHO stage 3 or 4 disease, individual presenting clinically well, individuals who are clinically stable on ART, and individuals who are receiving ART but that regimen is failing. So WHO definition of advanced HIV disease: for adults and adolescent, advanced disease is defined as one having CD4 less than 200 or WHO stage 3 or 4 event. All children younger than 5 years old with HIV who are not on ART are considered having advanced disease. But children older than 2 years who have been receiving ART for more than 1 year and are clinically stable should not be considered to have advanced disease. We know that CD4 count is not required at baseline for initiation of ART, but this baseline CD4 is still essential to classify patient into advanced disease versus those clinically well, as relying on clinical stage alone will miss out many such cases. People with advanced diseases higher mortality consequent to infections like tuberculosis, cryptococcal meningitis, pneumocystis pneumonia, and bacterial infections, bacteremia, and diarrhea and other bacterial infections in children. So what can we do to prevent and manage HIV disease at an advanced stage? There are studies which have assessed the potential for an enhanced package of intervention to reduce morbidity and mortality with an aim to reduce cost of hospitalization, opportunistic infection, earlier switch to second line if they are failing. These WHO guidelines for advanced disease include recommendation for screening, diagnosis, prophylaxis, and treatment of such patient. Most of the information came from 2 studies, that is Reality Study and REMSTART study, which were conducted in Kenya, Malawi, Uganda, and REMSTART study in Tanzania and Zambia for people with CD4 less than 100 and 200 respectively. And these included enhanced prophylaxis and enhanced OI screening and treatment. Results from these studies showed that there is a 28% reduced deaths, improved adherence at 6 months, and reduction in cryptococcal disease and hospitalization by 17% in those who are having enhanced prophylaxis as a part of the trial. So WHO package for care for advanced disease includes screening for severe opportunistic infection, screening people for symptoms of TB, screening for TB with urine lamp, for cryptococcal meningitis, the cryptococcal antigen lateral flow assay, providing preventive therapies like TB preventive therapy after excluding tuberculosis, cotrimoxazole preventive therapy to prevent severe bacterial infection, and fluconazole to prevent development of cryptococcal meningitis if the person is cryptococcal antigen positive but does not have meningitis. Another intervention is to start ART as soon as possible, what is called as rapid ART initiation, and provide tailored counseling to people with advanced HIV disease to support their care. So the key action under this package is screening with the sputum for expert MTB-RF as first test for TB diagnosis, urine lamp for TB diagnosis in patient with symptoms and signs of TB, with CD4 less than 200 for inpatient or less than 100 for outpatient. Cryptococcal antigen screening, preferably at CD4 count at less than 200, but definitely at less than 100 if the facility is available. Second key action is provision of prophylaxis and preemptive treatments. CPT prophylaxis for all those with CD4 less than 350, or clinical stage 3 or 4, or even any CD4 count in setting with high prevalence of severe bacterial infection. TB preventive therapy to all where the TB has been excluded. Fluconazole preemptive therapy for people who are cryptococcal antigen positive but do not have meningitis, particularly when CD4 count is less than 100 cells. Diagnosis, prevention, and management of cryptococcal antigen is very important because it is a serious opportunistic infection and a major cause for morbidity and mortality, accounting for more than 10% of all deaths among PL-HIV. So one should have a high index of suspicion among PL-HIV who come with unexplained headache and fever in absence of meningeal signs as well. So as I said earlier, they should be screened for cryptococcal antigen and prophylaxis be provided for those with cryptococcal antigen positive. When this is not available, all persons with CD4 less than 100 cells should be provided a fluconazole primary prophylaxis. Third key action is a accelerated ART initiation, which can be a rapid ART or a same-day ART initiation. And this comes from a systematic review by Ford et al. Published in AIDS 2018 on benefits and risk of rapid initiation of ART. And this involved a systematic review of all the studies in this systematic review, which included finally 3 randomized controlled trials, 11 observational cohorts, 5 qualitative studies, and 2 costing studies. And the results from these studies showed that there is a consistent evidence of improved clinical outcome, including reduced mortality across these studies. More patients initiated ART within 90 days when rapid initiation was the norm, and there was retention in care as well as suppression at 12 months was better in the rapid initiation. So the recommendation for rapid initiation is that rapid ART initiation should be offered to all people living with HIV following a confirmed HIV diagnosis and clinical assessment. This is a strong recommendation with a high quality evidence for adults and adolescents. And what is this initiation? This is initiating ART within 7 days from HIV diagnosis, but it can also be offered on the same day people who are ready to start. However, it is important that readiness is ensured to prevent defaulting. So full understanding and readiness of client initiated on ART is essential. Treatment must include accurate information and right to informed choice. Should be a collaborative decision. Right to decide when to start ART must rest with the client. Key action 4 is intensified tailored counseling support for people with advanced disease. They require closer follow-up during initial period of receiving ART to monitor response to ART as well as to identify signs and symptoms of possible iris. People who miss their appointment should also be rapidly traced by phone or through home visits. Where face-to-face visit is not possible, teleconsultation, mHealth, text messaging, other mobile interventions, or visit through a community health worker should be considered. Also, the ART staff should familiarize themselves with new counseling messages around rapid ART initiation, viral load monitoring, differentiated care, and U equal to U. Specifically for children, we need to follow approach of stop AIDS. Screen, treat, optimize, and prevent AIDS among children, following screening for TB, cryptococcal meningitis, and including screening for malnutrition, weight for height, height for age, mid-upper arm circumference as additional screening among children. Again, besides TB, cryptococcal meningitis, also assess for bacterial infections and also for severe acute malnutrition. Rapid ART initiation, preferably same day, but no later than 7 days after diagnosis of optimal regimen, and prevent bacterial infection through cotrimoxazole prophylaxis, TB preventive therapy, fluconazole, and also among children, pneumococcal vaccination, HPV, measles, and BCG vaccination. So I would like to acknowledge the support from my colleagues at headquarters for this guidance and presentation. Thank you for your attention.
So now it is over to Lena for the further moderation of the session.
Thank you, Dr. Puri. It's a pleasure to have heard Dr. Rewari's presentation on a very important issue, advanced HIV disease. Advanced HIV disease is something that, comes from experiences of at the early part of AIDS, where a lot of AIDS diseases are now being repackaged into an advanced disease package by the World Health Organization. So at the beginning of AIDS, at the beginning of the century, we lost a lot of friends and family to AIDS illnesses. At that time, we didn't have antiretroviral. And it in 2004, when the first antiretrovirals got rolled out, we thought, we had rid ourselves of these illnesses, cryptococcal meningitis, TB, pneumocystis, pneumonia. However, with experience, we now know that we need to do more to prevent and treat AIDS. So I'm going to ask Daksha Patel and Dr. Sajid and Vivek Rajanand to join me on the panel. Daksha Patel, as many of you all already know in the HIV movement, is the president of the National Coalition of People Living with HIV in India. And of course, she's the stalwart of the movement of people living with HIV. She comes from Gujarat. I've known her personally, and she's contributed a tremendous amount to improvement of treatment and care for people living with HIV in the country. Thank you, Daksha, for joining us. We have Dr. Sajid Kumar. He's the head of infectious diseases at Kottayam Medical College, Government Medical College. And thank you so much for joining us, Dr. Sajid Kumar. And we have Vivek Rajanand. Many of you all know the Humsafar Trust. It's a pioneer in India in the HIV/AIDS movement, the first community-based organization for sexual minorities. Does a tremendous amount of work on prevention, care, support, and treatment. And one of the few organizations in MSF where we have seen an organization contribute to operational research. So thank you, Vivek, too, for joining us on the panel. So I'm going over to Daksha. So Daksha, the first question to you, why in the era of antiretrovirals are people still dying of AIDS? And you have 5 minutes, yeah.
Yeah, thank you, Leena, and thank you, Dr. Puri sir, and them respected Revari sir and Dr. Manish. This is a very critical question you asked us that, yes, after 2005, we have ART treatment, and this program is scaled up in country very widely. But still, we are losing our community member who are on treatment. There is a biggest challenge. Already experts before me, they mentioned about non-communicable disease, advanced HIV challenges in community member. And there are whenever we will start something new, but always the challenge are also coming with very fast. So now this is the right, this is the time. It's not only we require to focus only on ART medicine, but we have to very focused on uninterrupted ART medicine supply to community member to achieve our last third 95 for viral suppression and to prevent mortality among community member. And the very important, along with ART medicine, we also need to focus other package of treatment service package. It's not only to we are providing ART medicine, but we also need to now focus on screening, diagnose, and treatment. Still, our program is highly now high time to come up with a TB LAM, Craig test, which are very, very important for to early diagnose for this advanced HIV disease. Just in quickly, I'm sharing here on Sunday, I met one very young community member who are admitted in hospital, and there is no any package of insurance or any support system. So because they diagnosed with TB in the brain, and he underwent for private hospital treatment, and that was a huge cost he paid. So we need expert, we need the all package of we already I mentioned, and as well we need along with ART center, the doctors who are providing our services, they must be expert to identify early screening of any advanced HIV challenges among HIV positive community member. So these are the major things we, if we will start to move on, we definitely prevent AIDS-related death.
Thank you, Daksha. Thank you so much for asking for these things. And it's really important to, be talking about these very important issues. We are losing about 60,000 people living with HIV in India every year, predominantly to AIDS illnesses. Dr. Sajid, I wanted to come over to you. I've seen in MSF, we work in Bihar, we work in a government hospital, we are running a clinic for advanced HIV, we provide hospitalization, we screen for cryptococcal meningitis, we screen for TB, we treat severe bacterial infections. Dr. Sajid Kumar, is there do you think, WHO has, defined the package of care? How far are we in India from rolling out the package of care, and what kind of support can we provide NACO in terms of operational research and working together on this very important issue of advanced HIV? And you have 5 minutes again.
Dr. Leena, and thank you, MSF. Thank you, ASHA services and other international organizations for all this discussion about advanced HIV disease. So I'm going to be very specific about advanced HIV disease only. As Dr. Mary has rightly said, advanced HIV disease management has been rolled out in 2017 and 25 years lost now. Before we are discussing why it's not being implemented in India. And advanced HIV disease is not a rarity at all. In fact, in spite of all the advances in ART therapy and all the advances in medical care that India boasts of, particularly during the COVID epidemic and even before that, it's a pathetic situation that even now 33% of people are coming with advanced disease to India. And I was talking to many of my colleagues from other states. Of course, Kerala is different, but from many other states, they have been quoting figures as high as 50 to 60%. So if such large number of people with advanced HIV disease are coming to us, we can no longer hold on to the old dictum of, keeping the patient waiting for so long for starting antiretroviral therapy and, waiting till they develop all the classical manifestations of opportunistic infections, waiting for the clinicians to investigate the patient left and right with the umpteen number of investigations before he comes to a conclusion, and all those things, In fact, we are seeing right now that there are many patients who come to us after 2 or 3 months of being inside many hospitals without being diagnosed as having advanced HIV disease, and only at the later stages, advanced stages, they come to the tertiary care centers. And in fact, we are not surprised in many instances, we lose these patients maybe within the first week of admission itself. They succumb to the opportunistic infections and they die of the disease. A disease for which we have an excellent cure available, almost cure. I will call it a cure because the patients are living for 15 years, 20 years, 30 years and whatnot. And that facility is available and it's not being provided on a regular basis to our poor patients. That itself, I will call it, it's not fair enough for a country like India to do that. Now, where are we lacking? That is the main issue that we are going to discuss. Where we are lacking is actually on the screening for opportunistic infections. In fact, unfortunately, what happens is, many of the ART centers are manned by people who do not have any specialized skills in diagnosis. So they are manned by people who are, well trained to handle the drug dispensing and conformity to the schedules, adherence, counseling, and all those things. But what is perhaps required in this advanced HIV disease is a pure clinical sense when we see the patients and trying to find out whether they have a stage 3 disease or stage 4 disease, and if they don't have that, go for the CD4 count and quickly do the urine lab test and crack test if it's available. And all these things, in a country like India, all these things can be managed within 24 hours time. And there's no reason why we should wait even for 7 days. So that facility, unfortunately, is restricted to a very few places in India. And I'm surprised when Dr. Leena was telling that, in Bihar, you have the facility to do the crack test and the lamp test. but it's unfortunately not available in many metropolitan ART centers. So this has to be the diagnostic clue to the clinician, and the diagnostic facilities, tools to be available to the ART centers is perhaps one of the most important things that we have to address. All of us know that advanced HIV disease patients come to us not with so many illnesses. They come to us with very few illnesses like tuberculosis, cryptococcal meningitis, toxoplasma infections, pneumocystic cerevisiae infections, and maybe tularemycosis in a few parts of India. So these are few diseases which can be easily picked up by a clinician with a minor clinical sense, and along with the available tools to start treatment early, we will be able to provide very good response to treatment and very good survival for these patients. Not only that, Dr. Vari was mentioning very much about the readiness to start treatment, and unfortunately this readiness is directly reciprocative to the efficiency of the counseling services provided to these people. And in fact, if we are able to provide good counseling services, and for that matter, India with the large number of ART setup, ART network that is available with all those link ART centers and all those care centers available left and right throughout the country, there is no reason why we should not be able to provide good counseling services. And in fact, our counseling facilities that are available either in the government sector or in the private sector or the so-called NGO sector is quite huge, that we can actually get the people ready to start treatment at the earliest possible. And as far as adherence is concerned, that's the other major issue with advanced HIV disease. Every study has shown that if we start treatment early and we can demonstrate to the patients themselves that this treatment works, the adherence level is definitely going to go up. And if the major issue concerned with HIV disease for the last 30-40 years, during which time I was associated with this, was about the stigma and the people's so-called, within inverted commas, the suspicion about the efficacy of treatment. Now we have got good evidence to tell people. Now we have got good evidence to tell them that, we know what you're suffering from, and so we know how to handle your issues. And therefore, with the existing network, I think we urgently need operational research immediately to find out why we are not able to do this, and to find out how we can actually implement the introduction of the diagnostic tools, as well as early initiation of ART, as well as pushing people to the readiness for treatment at the earliest possible time. And we cannot afford to have so many people coming to us with advanced HIV disease, which itself is contributing to the large number of deaths. And therefore, it has to be an urgent step which has to be taken very, 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 very urgently. Thank you. We'll come back during the question and answer.
Absolutely. Thank you, Dr. Sajid Kumar. In fact, you have highlighted the urgency of the issue. And I just wanted to sort of highlight that, yes, the crack test, we are waiting for NACO to roll it out. And we are doing the crack test in our clinics in Bihar. And we're receiving a lot of people from all over Bihar. For TB LAM, we are still awaiting the TB LAM in all the ART centers of Bihar, just like you mentioned, all over the country, because it was rolled out on a pilot scale. We have been pushing the company to file for registration, one of the biggest barriers, and we are hoping NACO will work with the Drug Controller's Office to register TB LAM very soon. So I'm hoping to see some good opportunities for us to respond to this urgency.
And the best thing that can happen after the ART rollout.
Absolutely. So I'm going to go over to Vivek Rajanand. And Vivek, I'm going to be blunt about it. What are the gaps in our HIV treatment program or diagnosis program that are now leading to people losing their lives to AIDS in 20 years, almost 20 years after we've rolled out the ART program? And of course, we can have the question and answers at the end of the session. Please go ahead, Vivek.
Thank you very much, Leena. So yeah, as someone who's been working, I always tell people that I was born in a NACO targeted interventions program 23 years ago. I've lived through some of the darkest hours. I've lived through the moment when, in 2002 in the Barcelona AIDS conference, we all were, we decided to lie down in the middle of the roads and demand treatment. From that point, we've certainly come ahead. We've certainly done well for ourselves. And I feel at a certain level, we need to congratulate our NACO program, the national program, which despite various challenges, has still kind of, we have a very good ART program in place. Having said that, I would just like to reflect and ask ourselves some questions that in this rush of chasing the second and third 95, somewhere have we lost focus on the first 95? Because when we talk about early detection, how robust is our prevention program now as of today? Where do we stand? And somewhere we need to strengthen that, because that is the first step. You detect early, you're on ART early, you detect undetectable early. So that focus somewhere needs to be strengthened, needs to be brought back in the prevention program. That would be my urge to our national program. Second point, what I feel is very relevant for us is, I have seen, we have our own clinic also, and I see that post-test counseling is basically about, a healthy lifestyle and, ART programs. But we need to have discussions that would involve access to advanced referrals, such as mental health, safer sex options with partners, nutrition referrals, adherence. Now, coming to adherence, our programs need to have dedicated interventions on adherence. We need to explore different strategies that are a combination of counseling-based approaches, peer-led motivation support, because peers play a very, very prominent role, and also knowledge on ART. Are people like, who are in an ART program, do they have complete knowledge? Do they have complete knowledge of the side effects? So that is one area we need to strengthen. We need to strengthen strategies such as multi-month dispensations. Like as on today, our programs, say you get 1 month's your treatment, but do we need to work on it? We've lived through the darkest hour of our life during the lockdowns, and we've seen the kind of challenges that we faced. And yeah, we in Mumbai at least had very good support from MDAX, and who allowed us 3 months dispensation. But to reach out to communities, help them access treatment was a very big challenge. So we need to look at ART delivery that is efficient and does not rely, you can't always rely on the PLHIV visiting the system. I may not want to go to the system very often. I may not want to go to my ART center every month. So can we do something where kind of we bring in that, so you can get your treatment, you can get your medicines every quarterly. Many a times people kind of drop out because they can't afford to travel. They can't secure leave from their workplaces. Let us understand, at least in Humsafar Clinic, we know that 70% of our beneficiaries belong from the low socioeconomic strata of society, and for them to take leave and go to the ART center, it's loss of their daily wage. So how frequently can they visit? Do we need to strengthen that aspect? Again, like Leena, you said, at Humsafar, evidence approach, the evidence-based approach, that we need to have more data. We need to have more data on adherence gaps. We need to understand the factors that kind of influence adherence among different populations. What are the resistance-based studies among different populations? Viral load monitoring. I have had this multiple discussions, but I still fail to understand that why we do not have viral load testing at the ART initiation. Why is it after 6 months? So questions we need to ask ourselves. But yeah, we kind of need to build more evidence, which is needed. Like we recently finished a 5-year NIH project, and we figured out that amongst the youth 18 to 25, in our people who enrolled in the study and who had never had any access to any kind of intervention, almost about 12 to 15% of youth in that age group were testing positive. So are our programs strong enough to kind of, to reach out these youngsters? And one of the major issues that we face is, look at the rural and the urban divide. We are lucky. We are lucky we are in large metros. Okay, like Dr. Sajid said, like, is it available, say, in a remote village of Karnataka or a remote village of Bihar? There is a very sharp rural and urban divide, and that brings about disparities, that brings about challenges where people cannot access that treatment. So somewhere I feel we need to have a holistic approach to treatment. We need to start addressing non-communicable diseases. There has to be a focus on nutrition guidance, access to treatment, PEP provision to serodiscordant partners. And yeah, so this thing has been brought up before also, focus on hypertension, diabetes. But in many cases, we have kind of intervened in providing legal support to communities that have been kind of thrown out of homes. They have lost their properties. That adds to a lot to their mental stress. So it's not just mental health counseling. They need that legal support. So for me, these are kind of, I could go on and on and on, but this is good for now.
Yeah,
Thank you.
I think we need to build a much more robust HIV program to prevent advanced HIV from happening. So
Yeah.
I'm going to open the floor for, questions and ask Dr. Anupuri and Dr. Bamrotia to join us. And of course, all the panelists that we already have. So Daksha, Dr. Sajid and Vivek, please remain for the discussion. And if Dr. Puri, if you could also join us, that would be really good.
Should I
Thank
answer?
you.
Yes, a few things are coming to my mind now.
Please do.
Many things you can ask Moon, but Moon cannot be given. Like we have got the limitations, but as you know that National AIDS Control Program, India has done, enormous job, and it has, as compared to the globally, definitely it is much better than many other countries. I can proudly say that.
Yeah.
And we have achieved that. Definitely many things, as Mr. Vivek Raj Anand said, that a few things I do agree, that counseling has to be, we have to have a robust counseling. Adherence is a must. Adherence definitely is a must, but we should add an element of some counseling for the PLHIV, that they have got some responsibility or moral responsibility for their partner also, especially so if they are discordant couple. They have got the moral responsibility to get themselves index testing is their responsibility. Although, yes,
Yeah,
it is not all that easy. Although it is not all that easy, then it is. We cannot compel them for under any circumstances. We cannot compel them, but some kind of counseling has to be done. Community-based dispensation, we are doing it. We are doing it many places, but from the many people, we are getting questions on that also. And we are going to refine it further. We are getting glitches in that. We are getting, just now, 2 days back only, I got a PMO inquiry. PMO, this thing, a letter to the PMO was written by somebody, a complaint, wherein it is written that community-based in community-based dispensation, there is a community is asked to dispense the medicine in absence of a pharmacist, and in absence of a doctor's prescription also. At that time, there is no doctor's prescription. Earlier, doctor has prescribed. Now we want to fine tune it. We have to do some fine tuning on the community-based dispensation, and we are for it. And we are happy that it is being done, and it will reduce our load only. I know that otherwise our program will not be able to further expand. As it was, I mean, non-communicable diseases, we are making convergence. We are definitely, I hope, I mean, the presentation by Manish and Dr. Bharat Bhushan, if you have heard properly, I mean, completely, then you might have found in the presentation that we are doing a lot, although in Manish's presentation it was there, that convergence, we are doing the convergence, and Government of India is very much have started it, but we are in an initial stage. We will do it. And TB LAM, definitely TB LAM.
Go ahead.
We should go for it, and cryptococcal antigen and other opportunistic infection also. But what about the cost? I need to know the cost, then only. And one minute, let me complete now. Once the question is asked, and I need to answer those questions. The TB LAM is these things are important things. Definitely, Dr. Sudhir Kumar has raised many things, but above all, many things are important. Many of the PLHIV are having their BMI less than 18, less than 17, less than 16. I mean, they are so low weight. We are not giving them nutritional support, and what to talk of these things. We should build up a system of giving them nutritional support, especially for that. And we are building that also. We are working on that, rather than that is a better thing. And the CD4 and other things are definitely more important. Viral load at the starting of the if on what is the scientific basis of starting the viral doing the baseline viral load? I mean, CD4, we are already doing it. Immunological failure, we have to find out. That is more important anyway, but if we can think over that also. Yes, that's all I want to convey. I mean,
there are more questions, so I'm going to line them up one by one.
Okay,
so I'm going to
please.
give opportunities for people in the audience also to, and thank you, Dr. Puri, you did a wonderful job of answering some of the queries from the panelists. So Dr. Sajid, there's a query, there's a question from the audience, and I'm going to combine two questions in one. Can we do TB screening at the time of ART initiation? So that's the first question. And if someone is has a crypto antigen, what's the dose of fluconazole for prevention therapy? So these are the two questions. Over to you, because you are the infectious disease doctor here. Please go ahead.
So I must congratulate the NACO once again, for organizing all these type of activities in different parts of the country in such an excellent way. But, we have to see that the so-called differentiated care, or the differential care that has been, proposed by WHO is put into action. The differential care that includes about triaging the patients into these things, sir. Now, coming to the question of what Lina was raising. Do we need to diagnose tuberculosis when we start ART? Definitely, there is no doubt about that. Because if the patient is having a low CD4 count, and if there be a situation where TB treatment takes priority over the antiretroviral therapy, we'll have to decide at the start of therapy itself. That is the reason why except in very severe patients, maybe with the TB treatment will take priority over the antiretroviral therapy. And that is the protocol that NACO has been advising all the time. Only thing is, if we are going in for urine lab, we will be able to pick up those cases where the clinical suspicion is not that much, or where the clinical suspicion is good enough, but we are not going to waste time on doing all the other umpteen number of investigations a physician would like to do for tuberculosis, diagnosing various organ system involvements, etc., etc. And regarding the question on, I think, fluconazole therapy, I'm not going to, specifically speak about therapeutics and prescriptions right now. But let us be informed that there is something what is called as a preemptive treatment. There is a preemptive treatment, or what we call as empirical treatment, where we, ensure that people who are suspected to have certain diseases with advanced HIV disease are preferably given this preemptive treatment as per the standard WHO protocols, which includes fluconazole, which includes cotrimoxazole, which includes even preemptive anti-tuberculosis or preventive tuberculosis therapy. So we are not going to discuss those clinical things in a session like this, but standard recommendations are available, which we can very easily implement through our standard NACO protocols, because these drugs are all available with us. We have fluconazole with us, we have cotrimoxazole with us, we have INH with us, we have even amphotericin. Amphotericin B also is not that difficult to obtain in the program right now. So we have all those drugs with us. Only thing is there should be a proper, streamlining so that, the actual needed people get these drugs. So that is where, we for differential care, the triaging, as well as the preemptive treatment, which can definitely benefit the advanced experience. Now, as I said before, many patients come to us and they die sometimes within hours, in spite of them being with the healthcare system for pretty long times. So that should be avoided, and that is possible when we actually go in for a good differential treatment policy. Thank you.
Thank you so much. There's another question for Dr. Bamrotia about what can we do to address issues relating to aging? And I'm just going to read it out to you. Yes, here is it. Can we recommend any special measures to reduce the progression of aging and the associated comorbidities in a PLHIV who's already on ART? And I think it comes specifically to you, Dr. Bamrotia, because you've been working on the whole issue of aging and comorbidities relating to age, and you presented on the panel. Please go ahead.
Yeah, thank you, Reena. Yeah, so thank you for that very wonderful question. So yeah, we do, like, obviously that with time passes, the age is going to happen, but I will take that question or remodify it, how we can avoid having detrimental effect or accelerated aging in PLHIVs. Right, so there are many factors which are beyond our control also, but then there are few which can be worked on. So the studies I have shown in the presentation clearly states that the longer duration of exposure to low CD4 or the longer duration of advanced HIV disease kind of makes a person living with HIV more prone or more accelerated aging. So the first thing is, as I think Vivek also pointed out, early detection of HIV, and then early initiation of ART, and preferably a very potent one. So NACO and Government of India have taken that steps, but still we see 40% of patients coming at really low CD4 count. So these are two very important aspects. Another thing is we just think of advanced HIV and low CD4 count at the registration. No, it's not like this. We have seen our patients becomes MES, becomes LFU, and then re-enter the system with an advanced HIV disease with a low CD4 count. That also needs to be addressed. That also needs to be prevented. So the all the that activities that are going around differentiated care, making patients, making the care more kind of acceptable, more patient-centric. And third, it's like not only HIV is a chronic disease. There are other chronic diseases which adds up to the thing, the aging process, like diabetes, hypertension. And not to forget, apart from these diseases, there are some habits like smoking, alcohol. How much time do we give in counseling PLHIVs on these? So these are very much important. The physical activity. So there are like going to be multiple areas if you want to kind of nullify the impact of accelerated aging that HIV brings on an PLHIV. It's not just one thing, but a comprehensive package. And NACO has started that discussion. It has come into the guidelines, the counseling on this risk factors, screening, diagnosis, management, everything. But operationalizing it, delivering it is going to be the next focus, which we need to focus on for upcoming years. I hope that answers the question. Thank you.
Very wonderfully. Thank you, Dr. Bamrotia. Your experience at the AIT program has added to the discussion here. So, Dr. Puri, I just wanted to turn to you. You spend so much time on a holiday with us. It's really great. So one question to you, NACO's been everyone's been affected by COVID. NACO's work has been affected by COVID. The advanced HIV package was in the works in 2019. And I believe it's also in, the TRG has met and there are new guidelines. When do you think we can have our next meeting, national meeting on advanced HIV? And when do you think this package will be rolled out? And we, of course, we are very keen to work with you and support NACO technically and otherwise as well. Please go ahead, Dr. Puri.
Next meeting like this, we can
I'm hoping physical, sir, where your clinicians can come and we can all be there to discuss. Advanced HIV disease. Advanced HIV disease is one of the biggest reasons for mortality in people living with HIV. And there was a meeting in 2019 that happened, which led to the current framing of the work that started in the framing of guidelines that are happening at NACO right now. And my colleague was also who attended it told me it was a very good meeting by NACO. I was just hoping that whether that can happen again.
So we'll be calling only the clinician within India or outside India also.
So India, sir, and all the technical partners that have worked with you with NACO. I think that would be a good meeting to have with the HIV network,
yes,
your clinicians.
Can you give me, give me 3 months? I will definitely arrange it. Or you want a little early?
Whatever, sir. I think 3 months is a good frame, and I think it's actually a good time to reconvene on this issue. And thank you for saying this.
Because I need to work on it also. Many things are lined up, and I have worked on those. So I have to close those things, and then only I'll get back to you. You can share your contact number with me. Or,
sir.
whosoever is coordinating on your behalf, on your side.
I will do that, sir. Thank you so much.
Okay. Thank you.
Thank you. And there's another question that has come in. Any of the panelists can answer it. Is that how often do you have to do the VDRL and hepatitis panel after you've been initiated on ART? So anybody who wants to answer this question, please go ahead.
How often VDRL and?
I'll read out the question, sir. The question says that how often do you recommend the VDRL and HEP panel tests if they're negative during initiation of ART? I'm assuming that they're asking, do they have to be repeated every year or at a particular frequency?
Okay, VDRL, if it depends on the
guidelines.
As per in case of HIV, we are repeating the test for HIV every 6 months for the high risk people. Those who are in the high risk, and those who are very high risk, it may be done in three months also. But the same thing, as they are comorbid condition, the same thing can be applied over there also. But they are VDRL, definitely the STI is a part of our comes under the HIV, but this hepatitis B is the different looked after by some other section of the ministry, but it should apply. Same thing should apply over there also. If the high risk people are being screened 6 months, then same should apply over there.
Thank you. So, Dr. Sajit, you have your, hand
yeah.
up. So please go ahead and also answer.
I'm not sure what the questionnaire actually meant, but to me it feels like, if you are HBsAg negative in the beginning, that's a good chance for you to initiate the patient on adult immunization strategies. We can start the hepatitis B vaccination if that has not been already taken. And if the patient is on ART, and we are quite sure that there is no further exposures that are happening which makes him risky, there is no need to repeat the HBsAg test at all, unless they have some clinical implications where a clinician would even otherwise do a hepatitis panel test.
Yes, sir.
As far as VDRL is concerned, as far as VDRL is concerned, again, the issue is whether there is a risk of continuous exposure, and that too with unprotected sex. If there is a risk of exposure, VDRL again has to be done on a diagnostic basis only. Unless the patient has got features, clinical features of syphilis, or unless the patient has got some other, suspicious type of unprotected exposures, that is the situation when we are thinking of redoing these tests. Otherwise, these tests done initially is good enough to categorize the patients into those requiring further protection and those requiring further personal lifestyle modifications. So there is no need to routinely apply these tests on a regular basis.
Thank you. So before I go over to Dr. Glory to hand over, I just wanted to give Daksha an opportunity to have a couple of minutes if she wants to add something to the discussion or any other issue that she wants to raise relating to advanced HIV. So Daksha, if you are there, would love to hear from you for a couple of minutes on what we need to do next on advanced HIV.
Thank you, Leena. And just almost we discussed a lot of points, but one in addition of advanced disease, we also need to now focus for aging PLHIV and non-communicable disease challenges, because yes, there is a number of community members who are already on treatment more than 1 decade, and there are many side effects and even treatment failure. Even we are discussing about advanced HIV diseases they are facing in their health issue. So this is also now upcoming new challenge. I will not say new challenge, but it is there. But we have to now address in our routine program on regular screening and treatment process.
Thank you. So I think that's a good point to make, that we can't forget, for example, women who are getting cancer as they age, or osteoporosis. So Vivek has his hands over, and then I'll come to you, Dr. Glory, to do the end the session. So Vivek, please go ahead. You waited so long, so please go ahead.
Yeah. So just quickly, when we are talking about advanced HIV, and if you look at key populations that would include MSM or trans women or women in sex work, IDUs, we have to understand that, with advanced HIV and with aging also comes various other disenfranchisement in their lives, and being thrown out of homes, lack of shelter, not being able to earn a livelihood. And somewhere we also need to look, it may not be the job of the health ministry, but it has to be job of the Ministry of Social Justice and Empowerment, but some social well-being, social entitlements, because one, you are PLHIV, two, you are aging. See, you have multiple stigmas. And then you are MSM, then you are a woman in sex work or a trans woman in sex work, disowned by a social environment. Unless we have a more holistic approach towards that. And taking the earlier question, when we are talking about VDRL, so we have very frequently seen, like Dr. Sajit said, that it has to be diagnostically assessed, but fact remains that among MSM and trans women, to whom our clinics specifically reach out to, we've seen a very high rate of VDRL amongst PLHIV. So you have your HIV positive, your adherence is not very good, and then you have unprotected sex, and there is VDRL. So VDRL, so we kind of encourage them, we frequently tell them so that they give their history more correctly, and then we can see, because a treatment of syphilis is there, it's immediate, it can be accessed. And also more counseling is needed at that point of time, that why the person is still into unprotected sex. Like I said in the beginning, it can't be just about ART and HIV. One has to have a larger look at it. One has to consider the mental health issue, why it's happening. And this is something, Lina, I've been struggling for the last 27 years of my life. It's not about use of condom. It's about why the condom was not used. And once we start analyzing the why, we'll be able to address a lot of issues around it. So that's all. Thanks for giving me the time.
Yeah, absolutely. Thank you so much to all the panelists. Thank you for joining us on a holiday, some of us in India, but also across South Asia, people who joined. And I'd like to introduce Dr. Glory Alexander, who's been waiting to give us. I would say that it's wonderful to have Dr. Gloria Alexander. She's given us so much support for this session. So I wanted to introduce you and hand it over to you, Dr. Glory.
Thank you so much, Lina. In my concluding remarks, I would like to thank especially Dr. Anup Kumar Puri, Deputy Director General of NACO and Chairman for this session. Thank you so much, sir, for being available at such short notice and for being able to come here and give so much of your time, especially during the festival of Holi. You have placed your interest for HIV higher than celebrating Holi, and being here with us and giving your input and showing your care and concern for all people who are working with HIV and AIDS and for all the stakeholders. So thank you so much, sir, for being available and for chairing the session. I would also like to thank all the speakers. In addition to Dr. Anup Kumar Puri, I would like to thank Dr. Manish Bamrotia, Dr. Bharat Bhushan Ravari, Daksha Patel, Dr. R. Sajid Kumar, Vivek Raj Anand, and of course, Lina Mengane, who conducted the session so well, the panel discussion as well as the question and answer session. So thank you to all of you for being here and contributing to this very important and interesting session on advanced HIV. Today in this session, we actually looked at two ends of the spectrum. At one end of the spectrum, we have people who are living for so many years because they are on ART, and then having problems related to aging and comorbidities. And at the other end of the spectrum, we have patients who have not even been able to access ART and who are coming in advanced HIV stage, 30%, 33%, and 20% of them are less than 100 CD4 cell count. So how can we improve this? All of you have given us so many strategies and recommendations. And to that, I would just like to add that, in the previous session, we did a session on self-testing. And that seems to be a very important strategy to increase diagnosis, especially for those members of the population who are hesitant to come out to a HIV counseling and testing center, but who would rather do self-testing at home with the help, of course, of counselors who treat them, who advise them virtually. The other thing that I would like to talk about is that we should have more involvement and empowerment of the key populations and peer-led services, because definitely this will help to reduce the stigma and discrimination and also maintain the anonymity and confidentiality that so many of them want. And the third thing is, of course, when we come to a care center, finally in an advanced stage, it is important that we have tests available to rule out opportunistic infections immediately, so that rapid ART can be started within a period of 7 days. So I think all these are important factors which contribute to improving our care and services in the field of HIV and AIDS. At the end of this, I would also like to thank all the participants, and we really hope that this session has been helpful and interesting for you. And we hope that this information shared and discussed will help you reflect on it at a personal and professional level. We would also like to thank all the participants who sent questions during the discussions, and we also encourage you to share the recordings with your colleagues who were not able to participate with us today. These will be available soon as the IAS Educational Fund virtual platform, free of charge, and they can join the platform anytime to watch the replays, which will be available next week. We would also like to remind you that this is the first day of the symposium. The second day of the symposium is tomorrow, starting again at 3 p.m. and going on till 6:30 p.m. Indian Standard Time. And the third session is a very interesting session on bringing the focus back to key populations in the HIV response, with a spotlight on people who inject drugs and co-infections. And the last session tomorrow is a session on HIV and TB. So we would like to remind all of you to please be there and log in to the link which we will be providing for session 3 from the homepage of the virtual platform, just as you have connected for these 2 sessions today. I also want to say that in addition to the 2 sessions that are going to be held tomorrow, at the end of the second session, there is going to be a short networking event. In the past, when educational fund symposiums were held, there was always a contact session after the symposium was over, where people could bond with each other and interact with each other over a cup of tea. But since this is a virtual session, that's not possible, but we thought we would do something that is similar to that, and therefore have a networking session after the whole symposium is over. And this will start at 6:45 p.m. tomorrow and will go on for about 30 to 45 minutes. This event will be held on Zoom, and you will be able to network with some of the symposium speakers and panelists, providing an opportunity for additional questions to be asked in a more informal setting. The registration link has been shared on the chat box, so please register if you're interested in joining that session. Please also remember to participate in the evaluation survey at the end of this meeting for the overall symposium. All participants will receive an email on Monday requesting that you fill in a survey to evaluate the symposium. We would greatly appreciate your feedback, which will help us continually to improve our symposiums in the future. And you can also write to the IAS Educational Fund team anytime at iasedu@iasociety.org. So thank you all for your participation. Have a good rest of the day and take care. See you all tomorrow. Thank you and good night.
Thank you.
Thank you all. Thank you.